had the Olympic lifter who improved all of his technique, increased his weight, had no pain, had no tightness, had no problems with the things that he was having problems with after just one visit. And the cool thing is when he came in, so yesterday was his second visit. He was originally coming in for left shoulder pain, left shoulder tightness that was limiting him with his snatch and his jerk, more so snatch than jerk. But so when he came in, so shoulder range of motion limited, pain with range of motion, weakness with testing strength, all secondary to neuromuscular dysfunction. So I did the same thing with him that I do with everybody. So started with his feet, worked our way all the way up to his shoulder and cervical spine last, gave him a couple quick things to do as far as warm up and cool down. Fortunately, he was not doing any mobility work before that, so he wasn't doing stretching and flossing and all the mobility garbage. So I didn't have to break any bad habits there, but I did have to give him some things to do for warm up to help reinforce what we had refacilitated. So cool thing is, when he came in yesterday for his second visit, he was astonished at how well his technique, or how fast his technique improved. So I saw him last week on I think it was a Thursday. He went and trained that night, and he had full snatch, normal form, good technique, was squatting much deeper in the catch because now he could get the center of gravity back behind over his base of support, so he wasn't leaning forward, he wasn't so erect, and he said, I couldn't believe how good my form was. So I didn't say anything about his shoulder, and so I said, so did it feel like you were thinking about it? He said, no, that's what was so crazy. My first rep, I dropped down, I haven't been in that position for probably over a year. So for a year, he had been compensating for a tight shoulder, which is going to throw off the rest of the movement. So when people want to argue with me about how this muscle doesn't control that joint because it doesn't cross the joint, that is absolute garbage, okay? Especially when you're dealing with people that are doing athletic things or they're athletic. So if you're tight and limited in one joint and you're trying to do some type of total body functional movement like a snatch, that joint will limit the rest of your body, okay? So just because a muscle doesn't cross a joint doesn't mean that it can't influence what's going on at that joint. So what did I work on in his shoulder? So his shoulder flexion when he came in was probably about like 10 degrees less flexion and abduction than he was on the right, so involved his left. So what was inhibited? So I went through and tested things. What came up inhibited? Serratus anterior, upper trap. I think we worked on delts, pec major, and that was about it. So it wasn't like it was a huge problem, okay? And subscap, okay? Not a lot of stuff. Worked a little bit on, I think we had delt and upper trap on the other shoulder. Got through his trunk. Trunk was the usual stuff, transverse abdominis, pyramidalis, glute max, glute med, soleus, that kind of stuff, okay? So just by increasing that range of motion and then getting proprioceptive input, so we have normal neuromuscular facilitation throughout the kinetic matrix, now he can go and do things and we're not trying to force him. So in the reel yesterday, he said, well, when I said, so what happened? And he said, well, it kind of self-corrected. That's the way it should be. You should not be telling your patients, think about doing this when you do that. Think about using this muscle. Think about contracting this muscle. Think about trying to get this muscle to relax, doing biofeedback and all that crap. The reason why that doesn't work is because you cannot consciously facilitate a contraction in a muscle that has neuromuscular inhibition. That is a fact. Can't argue that. That is why you move the way you move. So he was moving the best that he could before I worked on him. He was moving optimally after I worked on him because all I did was turn things on so he can actually use what he's supposed to use when he's supposed to use it in the angle that it's supposed to be in either a concentric or eccentric contraction. So what I just said there, if you've taken the mostrability course, you should be saying, yep, that's what we learned in mostrability. That's why I'm doing functional screen. That's why I'm doing what I'm doing in the clinic or in a gym with my personal training or sports performance people. Okay? Your job is not to give them verbal cues. Your job is not to force range of motion. So if somebody says, I feel tight, and you go mob them and you manipulate them and you stretch them and you foam roll them and you do whatever it is to open up more range of motion, all you did was cause decreased facilitation, which means now the muscle can't guard in that position, and now they have more range of motion that they can't control. So the more they do that, the more they beat up their joints, the tighter they get when they come back to neutral, because now that neuromuscular inhibition is saying, I can't regulate contraction. So remember, if the neuromuscular junction is not sensitive, then that nerve is not regulating tension, which means when that muscle gets in a short position and there's no feedback, no proprioceptive feedback from the nervous system, now all that muscle can do is contract and get stuck because the nerve is now no longer regulating, contracting more and contracting less. Okay? So if you are telling your patients, think about keeping your knees out when you squat. Think about striking your heel when you walk and then toeing off when you roll off. That is not going to work. Trust me, do your verbal cues and then watch them walk out to their car or watch them do something when they don't think you're watching them. They'll go right back to what they were doing before, because you cannot consciously break a compensation when you have neuromuscular inhibition. Fact. That is why most physical therapists, chiropractors, sports performance coaches, ATCs fail with their patients. So that's why you're using tape, and that's why they use braces, and that's why they use arch supports, because their body can't do what it's supposed to do. So now we give them all of this external crap to make them do what the normal is, which doesn't work. So the other thing that you don't understand is when you're coaching somebody to be normal. So I had this conversation with the Olympic lifter yesterday. He said, that was amazing. I can't believe how easy that was. And I didn't think about anything. And I said, so here's what you need to understand. If I took a video of you right now and I put that up against a video of somebody that just won the gold medal in the Olympics, and we looked at your snatches, they're not going to be the exact same. So I can't coach you to look like this guy over here. I don't want to coach you to look like this guy over here because you don't have the same anatomy. You don't have the same genetics. You don't have the same mechanics. You're not going to have the same looking lift. Now, it should be similar. There should be similar things that are going on there in order to be successful at that lift, but you're still going to be different. So if I treated this guy and I treated the guy that I treated, and they both came in with the exact same complaint, my thought process, my treatment strategies, all that stuff would be the exact same. But when I got down to the specifics of where their inhibition is, they're going to be different, which means I have to be able to get down to their unique limitation and reverse the limitation. Then when I send them out, they're going to be much better in their performance, much smoother, handling more weight, less breakdown, less fatigue, even though if we still put them side by side in a video comparison, they're still going to have differences. So there's no such thing as a normal foot or a normal gait or a normal squat. Your job as a medical professional or a sports performance coach or a speed coach or whatever it is to get your patients and your athletes to perform optimally on a neuromuscular level. Once you do that, you don't have to coach them to do things. You don't have to break bad habits. They don't have to work on mobility work. They just work the way they're supposed to work optimally because you're letting their body do what it was made to do. So just wanted to drop you that quick note. If you have questions on that, make sure you post questions down below and I will get to those later. Have a great day.